It is an honor and a pleasure to be able to present this webinar to the Peruvian Society of Radiology. Here are my honoraria. During this webinar, we will discuss the pathophysiology involved in COVID-19 patients, including disseminated intravascular multiple systems activation, not just a DIC variant. This involves widespread endothelial damage. The principal target of this disease is the alveolar endothelial interface. The concept of primary pulmonary thrombosis will also be discussed. Thrombosis risk assessment, we feel, is no less important in this viral disease than it is in any other patient. Recorded on admission, updated during hospitalization, and finalized at discharge. The value of post-discharge prophylaxis based on comorbidities and overall risk score is important. We will also discuss the anticoagulant dose adjustment based on comorbidities and/or high levels of D-dimer. In some cases, using therapeutic dosing for these very high D-dimer levels. Intermittent pneumatic compression will also be discussed, as it is important here as in any other patient. The risk of bleeding, including pulmonary hemorrhage, will also be mentioned. We will explore the role of the CT scan and ultrasound scanning in patients with this disease. There is also a real danger in performing elective surgery on patients who are COVID-19 positive, and this will be discussed. The American Venous Forum suggested guidelines will be presented. There are many guidelines, but we are presenting these based on our own experience with the members. Finally, discharge prophylaxis using different scoring systems will be discussed. Well, what about the coronavirus and thrombosis? What do we know so far? We do know that the novel coronavirus pneumonia was first reported in December 2019 in Wuhan, China. Coagulation tests were performed in 183 of these early patients, and the mortality of 11.5% was noted based on admitting laboratory parameters. These included D-dimer, fibrin degradation products, and prothrombin and partial thromboplastin levels, in addition to platelet count and elevated fibrinogen levels. Disseminated intravascular coagulation was seen in 71% of those that died compared to 1 of those that survived. So it seems that the death rate in this disease is based on the seriousness of the disease and the extent of coagulation changes. Sepsis may result from the viral infection, leading to activated clotting and hyperfibrinolysis. But more than that, it also involves activation of the complement and kallikrein pathways, as will be subsequently discussed. The authors of this original report, which were Tang and all, conclude that D-dimer and fibrin degradation product values may have prognostic significance and be important therapeutic targets. We know that the virus-induced inflammation triggers cytokine storm, causing tissue factor release, thrombin generation, fibrin formation, in order to coat the virus and prevent the spread of it. It's a very interesting mechanism, but the side effect is thrombosis. The activation of thrombin with hypercoagulability and elevated D-dimer levels as a result of the split products of fibrinogen to fibrin. Pulmonary thrombosis, DVT, pulmonary embolus, stroke, arterial thrombosis, all may occur. Microthrombosis may occur in the lungs, liver, kidney, brain, and other places. Fibrinolysis is activated in order to dissolve the thrombin that's being generated. And a DIC-like picture can result in thrombosis or bleeding depending on the consumption or production of the clotting factors and platelets. Now let's talk about the tangled hemostatic web. It has been known for a long time, based on the pioneering work of Oskar Ratnoff, who also described the original cascade of clotting factors and discovered Hegeman factor in his patient John Hegeman, which is factor 12. And he showed evidence based on experiments that were done actually before the turn of the century that showed that the activation of the contact activation factor, factor 12, can lead to platelet activation with platelet plugs and thrombosis, coagulation with the conversion of fibrinogen to fibrin and the development of thrombosis, fibrinolysis where plasminogen is activated to plasmin and causes clot lysis to try to offset the thrombin and fibrin formation that's occurring around the body. Inflammation is triggered, including elaboration of interleukin-1 by human monocytes, bradykinin, and complement activation, which can result in vasodilatation, increased vascular permeability, hypotension, angioedema, and other effects. And phagocytosis, in this case, can bind pathogens and cell membrane damage, which also occurs, and that damage also helps to activate coagulation. Here we see a brilliant cartoon by Iba and Levy. And as you can see, first of all, the cascade of clotting factors is noted here, and that's activated through Hegeman factor. But also tissue factor is activated as a result of neutrophils, which are activated, secreting extracellular traps for limiting infection, consisting of DNA, histones, and other neutrophil granular proteins, in order to try to surround the virus and isolate it. And you can see that occurring here. Unfortunately, the endothelium gets damaged. The endothelium is normally very protective of clots. It maintains vascular integrity, regulates vascular tone. Vascular endothelial cells release nitric acid, and this can be seen here, along with prostacyclins, thereby contributing to physiologic antithrombotic effects. Endothelial dysfunction and derangement of anticoagulation are the hallmarks of sepsis-induced coagulopathy. And we see here the damaged endothelium with an increase in spike of von Willebrand's factor and these nets. In addition to that, plasminogen activator and plasminogen activator inhibitors are secreted in order to offset this balance between thrombosis and clotting. And this winds up being a very abnormal situation here, resulting in severe derangement of the endothelium, and as we'll talk about in a minute, the endothelial-alveolar interface. Now, given all these changes, it's not surprising that heparins were very popular for the initial approach to this disease. First of all, for the anticoagulant effects, but look at all the different non-anticoagulant effects of heparins and related substances, including profibrinolytic effects, cellular regulation interactions, binding to inflammatory cytokines, and we know there's an inflammatory storm here, and also trying to inhibit neutrophil chemotaxis and leukocyte migration. All of these things are present in this disease. Unfortunately, heparin, of course, hasn't been proven to be enough to blunt all these pathways once they get activated. Now let's go back to factor 12. Factor 12 regulates inflammatory responses in human lungs, and this is an experiment in ARDS that discusses activated factor 12, triggering, as I said, the kallikrein and complement pathways and modulating cytokine pathways. Increased vascular permeability, protein leakage, hypotension, lung edema, vasodilatation. Angioedema can result in ventilation perfusion mismatches. And the authors postulate that factor XII inhibition may offer a novel and promising therapeutic approach to antagonizing the overwhelming inflammatory responses in ARDS lungs without interfering with vital hemostasis. So that's a very interesting concept. Here we see a picture involving bronchoalveolar lavage fluids of ARDS patients with measurements of factor XII. And you can clearly see that there's a highly statistically significant increase in factor XII in those that die, compared to, you would say it the other way around, a significant decrease in survivors. Let's explore this a little bit further. Back to the tangled web as opposed by Hageman. By Oscar Ratnoff, centered around the Hageman factor. As you can see, platelets, coagulation, fibrinolysis, complement, kallikrein systems are all activated with the net result of thrombosis, fibrinolysis, increased vascular permeability, vasodilatation, bradycardia, increased vascular permeability, angioedema, histamine release, and hypotension. Now, Oscar Ratnoff, when he came up with this, put forth the following postulate, and I'd like to read this. The thesis of my talk is not new. We think about clotting, fibrinolysis, immune reactions, and inflammation as if they were separate and separable processes. In truth, these distinctions are man-made. In real life, it is the body as a whole that responds to the injury. The process through which it defends itself are interlocked like the pieces of a jigsaw puzzle. We may be intrigued by the intricate nature of the pieces of this puzzle, but the picture emerges only when they are put together. Oscar Ratnoff, 1971. So we know that inhibition of the clotting system from the contact activation pathway can provide some protection against clotting. And here azistamab, which is a human monoclonal immunoglobulin G1 antibody that inhibits factor XI from activating the clotting cascade, has been developed and has been tested in total knee patients and shown to be similar to the efficacious prevention of thrombosis provided by both low molecular weight heparin and or apixaban. A single injection given to the postoperative patient is good for 30 to 44 days. Now, this may be another useful part of the cocktail for the COVID-19 patients, but based on all of our discussions so far, it's going to take a lot more than just inhibition of the activation of the clotting cascade through the contact activating pathway to be successful. This picture by Van de Verledonk is a beautiful depiction of really the essence of the pathophysiology in this disease, the predilection of the disease and the virus to attack the alveolar endothelial interface. And all of those effects which we've talked about, the vasodilatation, increased vascular permeability, activation of the inflammatory systems, the nets surrounding the virus, all can block this pathway. And of course, as a result of that, the patient can't breathe. And it's frightening and fascinating to see the ground glass appearance on plain chest x-rays that is seen in association with this disease. Now let's talk about risk assessment and talk about the Caprini score. I'm sure you're not shocked to find out that I'm going to be discussing the Caprini score for these patients. Now, aside from the obvious, the Caprini score was selected because it's the most comprehensive listing of risk factors relating to venous thrombosis. And of course, the more you know about your patient, the better you can protect that patient. This tool consists of 40 elements in the history and physical examination. And we know that as the number of risk factors increases, so does the risk of venous thromboembolism. So looking at 40 different factors gives us a good picture of the patient's number of risk factors. But then risk factors are different weights. So there are some factors that are at very low risk of causing a thrombosis, like birth control pills or bed rest, and others that are very high in terms of their association with thrombosis, cancer of the pancreas, lung cancer, history of thrombosis, family history of thrombosis. So there are different weights. So the score also assigns weights based on these factors and then combines the weights with the number of risk factors and comes up with a score. And the score is a nonlinear increase in the clinical VTE rate that increases with increasing score. As the score increases, the clotting risk of clinical clotting events increases. And this has been subjected to analysis in over 160 papers in 5 million patients around the world. And what it shows is shown here, for example, in one of the early studies in general surgery. Notice how there's a dramatic escalation of the VTE risk as that number increases. So it's only one road to Rome, but it's an easy way to be able to calculate a large number of factors, the relative risk of those factors, and a score which has been shown to be associated with venous thrombosis in an incredibly large number of patients. However, capturing all the 40 elements in the score is a time-consuming process, and this has been rightly used by adversaries of this score to say that this is too complicated, it takes too much time, and so forth. So, due to my association with a number of brilliant people from around the world, we've developed a patient-friendly form. And this is a collection facilitated by having the patient complete a preliminary patient-friendly form in advance of elective surgery or hospitalization, ideally with the help of family members. Patients' families should assist in completing the form at the time of hospitalization. Actually, before that, we now have changed our approach. We like to see everybody do that form today, and to take those results, correlate them with your personal physician, and then develop an initial number which will be your baseline score and put it in a safe place. This baseline score can be presented to healthcare professionals when you get sick, or in case you come to the hospital and you can't talk, you've had a stroke or are otherwise ill in an auto accident. This can be presented by family members. And it's very important that that preliminary score be then validated to develop a final score by the person responsible for the admitting history and physical. It's been done in a number of languages. Here are some of the ones that I know about that have been done around the world. It's a very friendly form with patient questions on 2 pages. And then again, that form can get validated finally at admission. Now, an important concept, whether you're using the Caprini score or any other score, is it does not stand alone at one time. It's a dynamic instrument. And during hospitalization, as the score may need to be revised based on things like reoperation, infection, central lines, newly diagnosed cancer, or other problems that weren't apparent. Patient, for example, was thought to be able to get up and walk but can't walk, and so forth. Develops heart failure. So an updated score will often result in a change in the thrombosis prophylaxis, including post-discharge recommendations. So it's indeed a dynamic instrument. Now, we are suggesting some addition to the score in the presence of the coronavirus pandemic. If an infection is present without symptoms, just diagnosed by the test, then we assign a score of 2, and often this will be in outpatients. And patients who get symptomatic, we add an extra point, and then finally in patients with an elevated D-dimer, 2 more points to give a total of 5. And don't forget that all of those numbers have to be added to the baseline Caprini scores, as well as calculating any risks for surgical procedures. Score needs to be updated during hospitalization and most importantly at discharge. Now we've known for over 100 years, probably 150 years, Virchow's Triad, and Virchow was a famous German pathologist who postulated when the risk factors of hypercoagulability, vessel wall injury, and stasis are present, that there's a high likelihood of developing a venous thrombosis. The surgical procedure and the operating room are a perfect dynamic test bed for the Virchow's Triad. First of all, venous stasis occurs in the legs due to calf muscle paralysis. When the anesthesiologist gives a muscle relaxant to intubate the patient, the muscles in the calf relax. Same thing happens with a spinal or epidural anesthesia. Then the veins get distended, and Philip Coleridge Smith has shown us in some beautiful pictures with a duplex scan how the veins get over distended under those circumstances. Then we also have a beautiful set of experiments from Tony Camerata and associates showing that when those veins get over distended, the lining cracks. And then when the lining cracks, that can have exposed collagen there that causes, that along with hypercoagulability forms a blood clot. Now, hypercoagulability occurs because the tissues are still metabolizing, so the waste products are sitting there. The patient may have hypercoagulable changes to begin with, especially with coronavirus. And so this all creates sort of a witch's brew to produce clotting with this exposed collagen. The time of anesthesia intensifies these effects, and it is critically important that pneumatic compression devices be used during this surgery to minimize these effects, particularly in longer operations. Here we see a 1,000,000-power micrograph showing the cracking in the endothelium with the exposed collagen in between the torn endothelium. And here we see the formation of blood clots that can occur in this subendothelial collagen. Now, when venous stasis occurs, white cells change into adhesion molecules, as seen by the darkening picture. And these adhesion molecules tend to slow down and land on the endothelium of the veins. And when this happens, they finally will release enzymes which will cause an inflammatory response, and that inflammatory response from these released granules will create holes in the endothelium, and then other white cells and adhesion molecules will come along and join. So now you have a damaged endothelium which doesn't work properly and contributes to the leakage of the blood into the tissues. Here we see a picture of that from the actual experiment done in the animal, and you can see here the adhesion molecule burrowing through the endothelial surface. It's a fascinating thing. Now, did you ever wonder why they tell guards when they're standing not to have their knees locked? Well, the reason for that is the Popliteal Entrapment syndrome. And when the knee is straightened, as seen here, or then slightly bent, you can see that due to the gastrocnemius muscle, on some patients, there is a compression of the popliteal vein that actually constricts flow. And as a result of this slowed flow, the blood has to go around it through the surface system. And this is just another factor that can be present at the time of surgery that can contribute to thrombosis. And so that's why we advocate putting a pillow under the leg of these patients. And we know that over 45 minutes of general regional anesthesia is considered major from the thrombosis standpoint. It may be a minor operation, but major from the thrombosis standpoint. It's very important. Let me say that again. A surgical procedure may be minor, but it may be major from the thrombosis standpoint because of the length of anesthesia and all of those changes that we just described. The longer the procedure, the greater the risk. Pneumatic compression devices on the legs or feet helps minimize the effects of anesthesia and sort of modulates these changes. And this is a must to help minimize venous stasis, endothelial damage, and hypercoagulability. A pillow under the knees helps avoid the straight leg position that can decrease blood flow out of the calf, causing the Popliteal Entrapment syndrome. Mechanical methods of prophylaxis are a critically important component of care, not only during the surgery procedure, but also in patients that are at bed rest and patients especially that have ventilators and are in ICU. And we recommend that the intermittent pneumatic compression be used during these times. There are some data that indicate that the pneumatic compression may not enhance the value of low molecular weight heparin in certain patient populations. But the major study that showed that was a study that had some difficulties. One difficulty was that only 2,000 out of the 16,000 patients screened were in the trial, so it wasn't representative of the general population. 5 different forms of mechanical devices were used, having different pedigree for efficacy. The duplex scanning in these patients was not standardized and varied from center to center. And so therefore, and we didn't have an individual risk assessment, so it's very hard to tell exactly how those results could be interpreted as negating the value of Virchow's Triad, which we know is operative in these patients. And so we need to get more data, but until we have more data, we need to be using pneumatic compression in our view in these patients, especially when they're non-ambulatory. And if we can develop further the portable products, they will be very good for those patients that go home and they're non-ambulatory, they have heart failure, they have pulmonary failure, they're on oxygen, they're weak, they're confined to a wheelchair. All of these are important considerations in the individual patient. Recently, a study was presented in a hospital population of 400 patients with COVID-19, including 144 in the critically ill group, and that was defined as patients who were intubated. They were in ICU, or they were intubated and had a ventilator. All of these patients received at least prophylactic anticoagulation. Now, in the overall series of 400, there was a 4.8% bleeding rate and thrombosis rate. Those numbers were higher in the critically ill, up to 7%. D-dimer elevation at admission was predictive of bleeding, thrombosis, critical illness, and death in these patients. And they only had 19 bleeding complications, including 1 death. And so on the basis of these data, the authors expressed caution for using intensified anticoagulation. But just like anything else, the devil is in the details. The level of risk of a particular patient has to be weighed against the relative risk of bleeding in a particular patient. And frankly, we have to wait for more analysis and studies because I, for one, could not discern the individual specific details of each type of bleeding problem and how they were handled, how serious it was, and what happened. And so you have to weigh the risks and benefits in this situation of each and every one of your individual patients. Making a blanket statement, in my opinion, that nobody should get more than prophylactic anticoagulation, or maybe that everybody should get therapeutic, can't be done. Again, each patient has to be individually analyzed. Another very serious problem is operating on the SARS-positive patient, and that can be associated with an extremely high morbidity and mortality. As you can see here, over 50% of the patients that were operated on that were COVID-19 virus positive, over 50% of them developed a VTE event, and about a quarter of them died. And the mortality at 30 days was even higher, 38% in those with pulmonary disease, and that accounted for most of the deaths. As well as males in age over 70 were serious factors in producing these morbid events. Now, I'd like to digress for a minute to one of my favorite topics, which I think has not been handled well by the authorities in various guidelines. Immobility. What is immobility? It's difficult to say what immobility is, but we do have some data. Remember, in 1999, the Medinox trial appeared, which was a worldwide trial comparing patients who are medically ill to receiving low molecular weight heparin or control without it during hospitalization. The results of the trial were very successful, showing that low molecular weight heparin decreased the incidence of venous thromboembolism in these critically ill patients. We also know that a subset analysis was done by a mean, and ambulation was tracked in these patients, and it was determined that if a patient in the non-ambulatory group could walk 30 feet, that their risk of blood clots was decreased from 19.7% to 10.5%, a 50% risk reduction. Furthermore, if they were in the low molecular weight heparin group and they could walk 10 meters or 30 feet, then their risk of thrombosis was reduced to a little more than 3%. So this appears to us to have been a very good definition, based on the literature, of what ambulation is. Now, if patients are using a cane or walker for stability and are not considered they're not considered to have restricted mobility as long as they can use their calf muscles, but in both legs. Sitting up in a chair or walking a short distance to the bathroom does not qualify as ambulation. So I was kind of surprised to see some very esoteric and well done analysis by some of our really thought leaders with the finest prospective data analyzed in the finest possible way. And yet when it came to them tracking the risk factors, they counted bed rest, if it was written in the chart, as not being ambulatory. Well, in my opinion, patients who sit in a chair or walk a short distance wouldn't be at bed rest. So I'm not really happy with that evaluation. Also, if a person has a cast, boot, or brace that inhibits the normal calf muscle action or the ankle pump action in one leg, they're immobile. We have data that show that venous duplex scanning flow rates are decreased in those patients that are immobilized in that fashion. And in fact, if they can't bear weight, their flow pattern is similar to somebody that's sitting. It does not go up. So these are very important considerations, especially with the COVID-19 illness, where ambulation is such a prominent clinical feature of the disease, both in the inpatient and outpatient setting. Let us talk about some of the recommendations that we have put together, and these recommendations, now you have to understand, are six or 8 weeks old, so we may be making modifications as we go forward. Number one, all patients should receive heparin or low molecular weight heparin prophylaxis on admission due to the high risk of thrombotic complications, including microvascular thrombosis. Remember, it's an endothelial-based disease, it's endotheliitis, wherever there are blood vessels. A VTE risk assessment we feel is necessary on admission. The panel used the Caprini score, which quickly identifies and quantifies comorbidities, as we described before, over 40 factors. The more factors present, the more likely you're going to make a good decision for your patient. It was found to consider doubling the dose of anticoagulation for scores of over 8, which would reflect a combination of age, multiple risk factors, ambulatory status, but also if the BMI is over 35 or the patient has heart failure, the dose of prophylaxis should be doubled. We'll also advise that for elevations of the BMI more than 2 times. If the scoring on admission is not feasible, we highly recommend it to score at discharge due to the high incidence of post-discharge prophylactic thrombosis. And those of you that don't use the Caprini score, stay tuned, because we'll talk about the other scores at discharge. Rescoring them is very important again, because many patients will go home who are morbidly obese, have limited ambulation, heart failure, pulmonary insufficiency with difficulty breathing, on oxygen, weakness, confined to a wheelchair, and so forth. Now, staying with the admitted patients, we recommend serial examinations, including a blood count, platelet count, PT and PTT, D-dimer, and fibrin split product levels, initially and serially. We feel that's important because some patients have dramatic escalation, particularly of their D-dimers, from 2 times normal to maybe 5 or 10 times normal. Similarly, the PT or PTT may be normal on admission, or the platelet count, but then go down as the patient becomes very seriously ill. Low molecular weight heparin prophylaxis, 30 milligrams BID or 40 once a day, can be adjusted for renal insufficiency, downward, or BMI of over 35 upward. And we feel that in patients with lower creatinine clearances below 30 cc's a minute, that low molecular weight heparin should not be used, and subcutaneous unfractionated heparin substituted instead. Again, doubling the dose for scores of over 8 or BMI of over 35 or heart failure, the group felt was important. And rescoring at discharge using extended chemical prophylaxis, again for those patients who are at high risk. Therapeutic anticoagulation was also suggested for selected patients who have suspected venous thromboembolism, but it cannot be proven for one reason or another. Those people that have gross elevation of D-dimer beyond 3 times normal and aren't at high risk of bleeding. We would like to recommend that DOACs, direct oral anticoagulants, the new ones, not be used during hospitalization. We don't fully know how to measure these. There are many interactions with the antiviral drugs, and we're much more comfortable using low molecular weight heparin or unfractionated heparin for inpatients. Different story once the patient is discharged. Fondaparinux can also be used for concerns about heparin-induced thrombocytopenia. And mechanical prophylaxis, we've already emphasized the importance of that, but particularly important when there's a high bleeding risk, including a low platelet count. And remember, with these high bleeding risk patients, that might not be absolute. In a day or 2 or 3, those patients may get to be in a lower risk of bleeding, so then anticoagulation can be restarted. The D-dimers are very important, and they track the severity of the disease and are a marker of worse outcomes. If the D-dimer is negative, ultrasound screening is unnecessary. High D-dimers should not be the sole indication for a duplex scan. Venous duplex scans should be similar to those used in non-COVID-19 patients for patients with specific symptoms, unilateral leg swelling, pain, or erythema, for example. And a normal venous scan should not be used as a marker that anticoagulation is unnecessary. Primary pulmonary thrombosis may be possible. In addition to that, patients can have thrombosis anywhere, micro or macro thrombosis. And using a negative scan as a criteria for full anticoagulation alone under those circumstances is not appropriate. And if full anticoagulation is determined to be necessary, then scanning shouldn't be done except to answer a specific clinical question. By all means, if you're going to scan patients, use the point-of-care ultrasound screening technique. And this is preferred in these patients, along with a handheld device monitored with a tablet or phone. taking those big machines around the hospital is inappropriate, and also they're very difficult to clean. So now let's discuss the inpatient algorithm of the American Venous Form Guidelines. If the score is less than 8, BMI lower than 35, and the D-dimer less than 3 times normal, we recommend standard low molecular weight heparin prophylaxis unless there's a high risk of bleeding. If DVT signs or symptoms occur, then a point of care ultrasound screening can be done with appropriate treatment if the clot is found. In those inpatients with a Caprini score of greater than 8, BMI of over 35, or a D-dimer less than 3 times normal, we recommend doubling the anticoagulant prophylaxis. However, if the D-dimer is more than 3 times normal, then therapeutic heparin or low molecular weight heparin should be considered, also considering the patient's risk of bleeding. Now let's go back in history, 2008. I had the honor to work with Juan Arcelas, who was a brilliant young surgeon that spent 3 years with me and later went on to be chief in Granada and have a very illustrious career. And he and his cohorts with Manuel Monreal, a very forward-thinking internist, who developed a RIETE database, international database of patients with blood clots. Doctors put their patients in there. They put in how they got the blood clot and how they were treated and what the results were. Real-world data. And there's now been over 90,000 patients, over 200 hospitals, and well over 100 peer-reviewed publications. It's a very important clinical database for us to understand thrombosis. And in 2008, when Professor Arcelas put this together at the time, he showed that 77% of patients got their blood clot after they left the hospital, and 55% of them once anticoagulation was stopped. What's really fascinating is that since that time, others have come out showing how the incidence of thrombosis is very high in these patients, and that if they don't receive anticoagulation for the period of time that is shown to be efficacious, they will still suffer a high risk of thrombosis. John Haidt, for example, a famous epidemiologist, tracking patients in Olmsted County and at the Mayo Clinic, noticed in the last 5 years preceding 2017 that the Mayo Clinic, gradually the doctors were using well over 90% prophylaxis. So almost all patients were getting prophylaxis. But during that period in time, the incidence of post-discharge thrombosis increased. And that was, he thought, and some of the rest of us agree, was related to the policy of stopping anticoagulation when the patients go home, which sometimes is after a very short period of time. Yet the regulations still to today do not advocate post-discharge prophylaxis in medical patients, except for some exceptions, which we're going to discuss here in a minute. Now, enter the coronavirus pandemic. This complicates greatly this situation because, if anything, these medical patients are now much higher at risk for thrombosis. Here is the American Venous Form outpatient chart. Patients with documented VTE that has been diagnosed during hospitalization, it's advised to continue therapeutic anticoagulation for 3 months and then reassess in the normal fashion. If the score at discharge is over 8 and the BMI is over 35 and the D-dimer is less than 3 times normal, then a DOAC is recommended for 6 weeks. If the D-dimer is over 3 times normal, then therapeutic heparin or low molecular weight heparin is recommended with a follow-up in 2 to 3 weeks with a duplex ultrasound, and if there's a DVT, then 3 months of anticoagulation and a direct oral anticoagulant for 6 weeks if there's no DVT. Now, not considered by the American Venous Forum panel, but also very important paradigms of extended thromboprophylaxis in medically ill patients are the following considerations, and this will be particularly of interest to those of you in the audience that use the Padua score or the improved score. And the FDA has now approved betrixaban and rivaroxaban for both in-hospital and extended thromboprophylaxis in high-risk medically ill patients at low risk of bleeding. And it's envisioned that over 25% of patients will fall into this category. It was also observed in these studies, and we have 4 of them now, ADOPT, Magellan, Mariner, and Apex, that 60% of all VTE events occur after hospital discharge, with 80% of them occurring within 6 weeks. And despite this, data show that less than 4% of patients are sent home on prophylaxis, as we previously discussed. Symptomatic VTE rate more than doubled during the first 3 weeks and 5-fold increase in fatal PE events within 45 days. So again, these trials, ADOPT, Magellan, Mariner, and Apex, have shown the value of betrixaban and rivaroxaban for prevention of VTE in medically ill patients, including after discharge. And the Padua Improve and Improved D-dimer scores have been used in these studies. COVID-19 magnifies all of these statistics. We don't have the data yet, but anyone who has even a very primitive knowledge of COVID-19 will realize these facts. In a little more detail, we see here the use of the improved score and the Padua score to prescribe outpatient prophylaxis for 6 to 14 days. And that was compared to the use of the improved score, especially in this particular evaluation, for a thromboprophylaxis of 31 to 39 days. And that showed that both betrixaban and rivaroxaban statistically significantly lowered the incidence of venous thromboembolism. So we would advise people that to make sure that you're scoring patients and make sure that you're paying attention to the post-discharge prophylaxis. Finally, in patients with the COVID-19 diagnosis, we recommend performing thrombosis risk assessment using your favorite tool, Many Roads to Rome. Evaluate your patients individually. Understand the widespread involvement of the vasculature in this disease. It's endotheliitis. Pulmonary thrombosis and alveolar endothelial damage are prominent features of this disease. Arterial or venous thrombosis can occur anywhere. Tailoring the intensity of anticoagulation is the key to success. Perform ultrasound scanning only for specific indications, and please use the point-of-care ultrasound screening technique, including a handheld device with a tablet or phone for recording. Avoid elective surgery in COVID-19 positive patients and understand the risks associated with operating on these patients if urgent or emergency surgery is necessary. And please remember that post-discharge prophylaxis is required for most patients, and I think that subsequent studies will prove that to be true. So I'd like to thank you all for your attention and participation in this webinar. Please visit my website at venusdisease.com or my YouTube site at Venous Resource Center for more information. And please, everyone, stay safe and have a great day.